Welcome to Nursing 542 Module 9. This week's module addresses the management of neurological conditions in the primary care setting. Seizure disorder. The goal of treatment with seizure disorder is control of the seizures and maximize quality of life. The treatment provided to patients experiencing seizures will vary depending upon when in the disease process you encounter the patient. Patients with new onset should be worked up for potential secondary diagnoses, for example, stroke, which is the most common cause of seizure in the elderly. Newly diagnosed epileptics should be referred to a neurologist, and then you can work in collaboration with a specialist to manage the disease. A high percentage of patients experiencing seizure disorder also suffer from depression, so be sure to screen and treat accordingly. Medication review is an important aspect of management with patients suffering from seizure disorder. Education regarding the need for strict medication adherence is key, as well as regarding the risks associated with abruptly halting the anticonvulsant medications. The newer medications are generally not as toxic as the older ones and have fewer side effects. However, they are more expensive. Patients should be asked to maintain a diary documenting their seizure activity, precipitating circumstances, and post-seizure symptoms. Surgical treatment may be an option in those patients whose seizures are related to a focal structural lesion. Parkinson's disease. There is no known cure for Parkinson's disease, so treatment is aimed at controlling the symptoms. There's controversy over when to initiate pharmacologic treatment. Starting early may slow progression of functional deficits, but increases the risk of potential side effects from the medications such as dyskinesia or ataxia. The general recommendations now are to begin treatment when the patient's symptoms are beginning to impact his ability to be employed or perform normal ADLs. The goal should be the lowest dose and fewest medications that can be utilized to provide sufficient symptom relief. Management of Parkinson's disease typically requires a team of providers: neurologist, physical therapist, occupational therapist, speech therapist, for swallowing assistance, counselor, psychiatrist, dietitian, and home health aide may all contribute to disease management. Referral to neurosurgery for treatment may be appropriate for patients exhibiting severe symptoms that are resistant to pharmacologic treatment. Exercise and diet are extremely important aspects of the management of Parkinson's disease. Referral to physical therapy and a dietitian may be necessary. Fall prevention will become increasingly important as the disease progresses. As a primary care provider, you should screen all Parkinson's disease patients for depression and treat accordingly. Refer patients and significant others, family members, to local Parkinson's disease support groups. Sleep disturbances, constipation, aspiration pneumonia, pulmonary embolism, urinary tract infections, sepsis from skin breakdown are all complications that can occur with decreased mobility and progressive Parkinson's disease. Parkinson's patients should be advised to get pneumococcal and flu vaccinations annually. Stroke. In the primary care setting, your job is to recognize a stroke and have the patient transported urgently to the nearest ED for acute treatment. Maintenance of the ABCs is the primary concern initially, of course. You do not want to aggressively treat hypertension when you suspect a stroke, as some degree of hypertension may protect against hypoperfusion in the ischemic patient. Following the patient's discharge from the acute setting and perhaps a rehabilitation unit, your role as primary provider will be to work in conjunction with treatment team members to maximize patient's function and manage any symptoms. Occupational, speech, and physical therapists may be included on the treatment team. Physiatrists, or also known as rehab doctors, cardiologists, neurologists, and psychiatrists, referral and or consultation should be undertaken as appropriate. Patients and family members should be educated regarding contributing factors that may have caused the stroke, risk factors, treatment plan, and early identification and avoidance of recurrent stroke. Referral to local support groups may also be appropriate. Screen for and treat for depression. I feel like I'm repeating that over and over, but that's quite a common occurrence with most patients suffering from neurological disorders. Patient and family members should be educated on the role that exercise and therapies can play in regaining function, depending, of course, upon patient's degree of disability. Set realistic and achievable goals. Have the patient participate in treatment plan decision making as much as possible. Bell's palsy, the goal of Bell's palsy, because it typically resolves on its own within 4 to 6 months. So the treatment that's necessary is to protect the eye, and you want to have the patient tape it or patch it at night to prevent secondary injury. Glucocorticoids and antivirals may be helpful early on in the disease. The main concern is avoiding corneal abrasion and injury, as I mentioned. Artificial tears and patching the eye at night protect the eye from injury. Brain tumor goals of treatment and primary care will be to support the patient through the treatments, monitor for complications and side effects related to treatments, collaborate with specialists, and monitor for reoccurrence. Treatment for brain tumors is typically provided by specialists including oncologists, both medical and radiation, and neurosurgeons. Treatment typically consists of surgery, radiation, and/or chemotherapy, but this is of course all dependent upon the tumor location and type and the stage of the disease upon diagnosis. As a primary care provider, you will need to communicate closely with the specialist so they are aware of any treatments that you're providing that may impact their treatments or patient's condition. You will want to support the patient and the family throughout the course of treatment, advocate for holistic care, and refer to hospice and palliative care as appropriate. If you have a patient with a history of brain tumor, then you want to ensure that they receive recommended follow-up screenings to monitor for reoccurrence. Degenerative neurological disorders. Goals for ALS are to slow the progression of the disease. Goals for treatment MS is delay progression of the disease, treat exacerbations, and manage symptoms. Patients with ALS or MS will require referral to a neurologist. A team of physical therapists, occupational therapists, dietitians, specialists, and primary care provider will be appropriate for most patients. The majority of ALS patients will be appropriate for palliative care and/or hospice referral. Treatment for the remitting, relapsing MS are more successful than those for progressive forms of MS. For both MS and ALS, pain control will be a key aspect of management. Multiple sclerosis patients and their families will require education regarding the disease progression, medications, symptom management, diet, and exercise. As with all patients suffering from a chronic illness, MS patients should be screened and treated accordingly for depression, as should ALS patients. ALS is typically a fatal disease. Average survival runs about 5 to 6 years. There's only one pharmacological treatment, glutamate antagonist, riluzole. I don't know how you pronounce it, but it's the only one found to slow the progression at all. Alzheimer's disease goals of treatment are listed here. The treatment of Alzheimer's disease includes addressing any underlying contributing factors such as vascular disorders. Patient safety is a major aspect of Alzheimer's management, as is psychosocial support for both the patients and their families. Depending upon the severity of disease, respite care, support groups, and referral to palliative care and hospice may be appropriate. Discussions regarding legal, financial, and end-of-life decisions should be undertaken early in the disease process, if at all possible. Anxiolytics, antidepressants, sleeping aids, and antipsychotics should be utilized only when non-pharmacological interventions are ineffective and behavior is severe. Close monitoring of response to pharmacological treatment and potential side effects is vital. Peripheral neuropathy. Obviously, the primary aim when treating peripheral neuropathy is to address the underlying disease. For example, if diabetes is contributing to the neuropathy, then improve your blood sugar control if possible. If vascular insufficiency is contributing, then address that. Many of the diseases known to contribute to peripheral neuropathy may be improved by lifestyle changes such as smoking cessation or weight loss. These are the medications typically utilized to relieve neuropathic discomfort. Opioids should be only utilized if pain is unresponsive to non-opioid medications. Restless leg syndrome. Conservative measures such as massage, avoidance of caffeine and alcohol, sleep hygiene promotion should be attempted prior to initiation of any pharmacologic therapies. Again, I know that there's a lot covered in the neurological module. Please post any questions you have under the course communications tab so we can all benefit from the information. Thanks.